Cyanoacrylates are a group of compounds that has been successfully used as a biologic tissue adhesive in ophthalmic surgery. They undergo immediate polymerization and adhesion on contact with fluid. Cyanoacrylate retinopexy was historically performed, but it gained less attention after development and availability of silicone oil and heavy liquids. Coloboma is a congenital anomaly secondary to incomplete closure of the embryonic fissure, leading to absence of normal retina, retinal pigment epithelium, and choroid. Success rate between 57% and 87% have been reported in eyes treated for retinal detachment. The reason for failure is mostly attributed to absence of underlying pigment epithelium that helps in creating chororetinal adhesion around the break. We herewith present surgical technique of cyanoacrylate retinopexy for failed surgical repair for Colobomatous retinal detachment. The surgery was performed under peripheral anesthesia using 23 gauge trocar. 3 ports were open as with regular vitrectomy. The infusion trocars and cannula were confirmed and continuous irrigation was established with a bottle height of approximately 60 to 70 cm from the patient's head level. All the cases had silicone oil in situ and required removal. The fundus was then evaluated for previous sites of break and searched for new breaks. Membrane secondary to proliferative vitreoretinopathy were peeled, edges of the breaks were cauterized using intraocular diathermy. Fluid air exchange was performed and retina was attached under the pressure of 30 to 35 mm of mercury. Additional breaks which were found apart from Colobomatous break were barraged with 3 rolls using indolaser and applied viscoelastic substance over the posterior pole using 23 gauge cannula and injector to protect the posterior pole and the macula. A 0.3 ml to 0.4 ml volume of cyanoacrylate was aspirated on a 1 ml syringe. The injector was introduced into the vitreous cavity with its tip at the level of the retinal break. Before the injection of cyanoacrylate, the air pressure is to be lowered to around 12 mm of mercury to 15 mm of mercury. Higher pressure was found to cause difficulty in pushing the plunger. The plunger was slowly pushed until a drop of cyanoacrylate was visualized at the tip of the cannula, around the break and over the area devoid of retina. The injector was removed and a sealant was checked for drying using a 23 gauge blunt cannula after 30 seconds for polymerization. A further wait for at least 1 minute is done and the globe is left atmospheric or C3F8 gas. The retina was evaluated over 2 to 4 weeks up to 8 months post-operatively. At the end of the follow-up, the retina was attached with a final visual outcome of 2 cases where 360 and 560 respectively. The application of cyanoacrylate for human eye was first reported by Florborn, who treated giant retinal tear after perforating injuries with vitrectomy and cyanoacrylate. McQueen et al. In 1987 used transvitreally delivered cyanoacrylate tissue adhesives to seal retinal break in selected patients undergoing vitreous surgery for complicated retinal detachment. In conclusion, cyanoacrylate retinopexy can be used successfully for retinal detachment surgery with appropriate vitrodynamics, particularly in patients with Colobomatous retinal detachment that have failed previous retinal detachment surgeries. It can produce good anatomical and functional outcome without the need of additional tamponade and head positioning.